to NUR 203, HESI Q&A, RN, PN, doesn't matter. You all need to see the same thing. It's what you do with the information that's different. So we're going to go through what to do with information today when you see things, because there's so much pediatric stuff. So what do you need to study, right? Growth and development and all the theorists and each condition, right? There's a lot of stuff. So I try to make it a little bit easier for you. So what I have done to help you is I've gone through several from the very beginning of time with me with doing HESIs, which is since 2017. I've been looking at HESIs, those concepts missed by students, and I tried to follow them up by making questions in my Kahoots. Okay, so if you've seen Kahoots, you're like, those questions were no concepts on an exam. Well, I guarantee it's going to be on the HESI or on your NCLEX, because that's the way I work. It's either PowerPoint, it's Kahoots, or and now I'm trying to make you think with my HESI Q&A. All right. So these are concepts, broad concepts. I'm trying to get you to think more broadly, not just memorizing a certain information about something. So you've heard me say this how many times? Nutrition, nutrition, nutrition. So you're going to get many questions about nutrition, and we've learned a lot about it. So you have a child who has an irritable bowel syndrome. So we know that a lot of the nutrients are not being absorbed and used, right? Nutrition is going to be a huge issue. So, what's one thing that we're going to monitor? Yes, height and weight. That's a given. But remember, in especially smaller children, you're going to look at cognitively delays, developmental delays. Are they not lifting their head, turning over? If they're not getting the nutrition they need, you're going to see it in some sort of developmental delay, whether they're not moving the way that they should, rolling over when they should, they're not walking or standing by 1 year old. That's a delay, and it could be related to nutrition. Okay. That's why height and weights every visit, and why we know all these developmental steps. All right, let's look at the infant and reflux, gastroesophageal reflux disease. Now, this was the last exam, we covered it. Remember, what happens in reflux is what? They're losing nutrition. So why do we put rice cereal in a brand new infant's bottle when we don't feed them till they're 6 months old? Well, it's better to give them something they might lose through their stool so that they don't vomit and they save all the nutrition that they were spitting up before. So that's one of those takeoffs, and it works. Of course, with the rocking, burping, sitting them up, and never putting them on their laying them down right after they eat, and not overfeeding them. So nutrition, different questions, right? All right, then you have a kid who's sick, has osteomyelitis. Remember, what helps in healing? Proteins, right? Protein, bone healing. So you got to remember calcium, vitamin D is milk. If you're lactose intolerant, what do you do with that? You're going to have to put it in some other way. This is what I'm talking about with osteomyelitis. Healthy foods, going to be high in protein. So fat, whole grain breads, beans, lean meats, and fish, and low fat things, because fat causes a lot of gas. And if you're in with osteomyelitis, you're not moving, you don't need extra gas, because that's going to hurt. And that's why that. All right, and nutrition. We always look at height and weight, right? So when we're looking at overweight, underweight, it doesn't really matter. A child who's not the normal, in their weight, it's the best thing. Adult, infant, child, school age, don't matter. Get a history, a diet history, whether it's 24-hour, 3-day history, something. Find out, what are they eating? And we can say, oh, we're pinpointing, it's because of this child is obese, or maybe we can change this to this diet. So A diet history is always going to be your answer about how to treat obesity. Also, are they up and out and are they moving? Is there physical education in school? And are they in it? And again, that's a start. Okay, nutrition again. Celiac disease. It's not just knowing wheat, rye, barley, and oats, is it? It's knowing what are they. And as you have a patient who has celiac disease and they're getting a, let's say, a clear liquid dinner or a full liquid dinner, and they put crackers on a tray or something, they can't have crackers. That's some sort of wheat, rye, barley, or oat flour. So again, being aware of what's on the breakfast, lunch, dinner trays and not serving it because some kids will just go ahead and eat it because it's there. Oh, I didn't know it was on the tray. And it is your fault. It is your fault. So take accountability for that. All right. Those good old white patches on the tongue that can't, you try to scrape them, right? And they can't come off. And you're like, oh, what's going on? My baby has milk tongue. Well, no, it is, yeast infection and it needs medication. How do we give the nystatin to a baby? We don't swish and swallow. An infant don't know how to do that. What you do is you take a cotton swab and dip it and then just rub it on the white areas. And that's the way you give nystatin. That was an exam question way back. All right, you get phone calls from parents a lot of times. My baby's not sleeping all night long. What can I do? What can I do? I don't know what's happening. It could be as simple as a diaper rash. Can you imagine having it open like that little diaper rash down there at night, and all of a sudden you stool or you urinate, and all of a sudden it's now burning? That kid's going to be awake all night long. So, diaper rash can keep those children up all night long, and to treat it is all different treatments, keeping them off their diaper, different ointments. It could be foods that were introduced, new diapers, creams, all of those things would be looked at. But diaper rash, simple diaper rash, can be something that could be exhausting to parents. Remember, when we feed babies, it's usually at 6 months and it's one food every 4 to 7 days. And the reason is we're looking for allergies. And the allergies could be a diaper rash. The allergies could be spit up, could be vomiting, could be abdominal discomfort, could be a total body rash, could be many things. Okay, let's go to infants. Things that are important. Well, I think one thing I have emphasized in my classes is infants and their fontanelles tell the world about everything, and they really do. So, if a head circumference is increasing, what's the next thing am I going to look at? Of course, it's the head, always. I'm going to look at the fontanelle. Any child who's less than 1 year old should have their anterior fontanelle is still open. And you could see fluid balance and you could see dehydration in that little sunken dehydration rounded. Now we're showing that there's fluid, which could be hydrocephalus. One of the things about infants and some conditions like your transesophageal atresia, TEFs, and your esophageal atresia, transesophageal fistulas, and things that gastroschisis, and you can't have them eat. Well, do infants explore the world and comfort themselves in their mouths? So, in order to promote normal growth and development, the first thing is always a pacifier with them. They soothe themselves and they comfort themselves here. Very important for us to remember. And looking back through the years, and any of you who are older nursing students, they didn't like pacifiers years ago. But through research, and we found out that infants do so much better by soothing themselves with something in their mouth. And it's better a pacifier because we can shape their teeth and their mouth and their gums, etc., instead of a finger. My daughter was a finger. She liked that one. Right. Then you've got the good old mother who comes in and says, my baby boy was different than this girl and seemed to be doing what my other baby was doing. So what do we say in all cases? all children are different and they all evolve and they all grow differently. Now, what do we should be doing? Well, we know that they should be sitting their head up by 3 months, rolling over by 6 months. The biggest question they like is sitting unsupported at 8 months. That's always a question around here, always. I don't know why, but it's sitting at 8 months unsupported. And then, of course, at 12 months, it's standing, walking, or attempting to. So, as long as they're there doing that, I don't care who's first or second, or who's quicker or not. You might see one catch up later. Now, FTT is failure to thrive. This is that child who, no matter what they're eating, does not gain weight. This also could be the cardiac child who also is eating and tuckers out really quickly. So they're not getting the nutrition they need. That's what this means is failure to thrive. They're not growing in the manner the way that they should. So one of the easiest way to help these children is decrease the amount of formula breast milk they need to drink by increasing calories. And you can increase calories in breast milk also. It's called a breast fortifier. You actually add sugar to the breast milk, is what it is. So a couple of calories per ounce. So it would be what we would have to do in order to get that child nutrition back where they need to go. Because failure to thrive, they're not going to be cognitively where they need to be. They're not going to be the height and the weight they need to be because they're not getting the nutrition to fuel the tank. So they're not going to grow. They're not going to be aware. Okay? Very important concept. Now, toddlers. Remember, toddlers are all about mommy, daddy at bedside. Okay? Toddlers on their level, down on their level, play with them, use a doll. Okay? Important. Get down on their level and then talk to them on their development. Preschoolers. Well, we've learned all about these guys. These are talking, they speak, they're getting more and more verbal and more agile as we go along. Autism. Now, autism is usually diagnosed right around 2 years old. And the reason why all of this stuff came out about autism and the chickenpox vaccine is because we give the chickenpox vaccine right about that time. Usually 18 months, kids are always sick, so they're delayed. So they think it was the chickenpox vaccine which caused autism. Well, they ruled that study out, and no, it doesn't cause it. We know through education that immunizations prevent diseases, and that's what we want to do for our kids. Now, there is a question here. Now, every hospital, every whatever has their own type, but this is one of them to let you know that there's a way that we as nurses go through and we can check things off and figure out so that we can get it to the doctor, to get to the neurologist, to get proper care. Okay, school age children. Now, school age children, remember, these are the ones that are more awake, more alert, aware of their past. Their reactions to previous hospitalizations is huge. If they've had a bad experience, they're not going to be happy with you this one. So again, very, very important that we communicate with these children again on their level. Now, school age children. You have kids at this age where they're great, growing a lot during this age. It's ages 6 through 12. And we have some children by the age of 9 or 10 that are the shortest kids in the class. And you're like, oh my goodness, what are we going to do here? Well, some of these kids are in families that are short. You cannot increase their height by giving them like growth hormones, right? But in a child that their normal family members are a normal height, that we can give them growth hormones, subcutaneous injections daily in order to get them up to where they need to be. Another thing with school age children is they're worried about their brothers and sisters at home. We're lucky today with FaceTime. But I would always send home colored pictures. I would make ribbons with bows. I always had ribbons that I brought into the hospital and made bows for all my little girls. And we would send home to sisters or mother or whatever. Very important to incorporate them into the care with school age children. Now, adolescents. One of the things about children, adolescents, is we need to keep them with other adolescents, all right? Um, that communicating back and forth, for instance, they have a congenital heart defect, right? You have other children with congenital heart defects in the hospital, adolescents, putting them together. They can exchange their fears, their stories, and it gets them more aware, again, getting them more involved with their treatment. Now, we did learn Tanner stages. Remember, one is where you're just a baby body, okay? No puberty. And 5 is where you're completely changed. It starts out with number 1, breast buds enlargement on female and an enlargement of scrotum on males. And then it goes up to, complete. Now, there's been questions on which stage would it be. The only thing I can tell you is if you know that 2 is the breast buds and 5 is a complete, it's somewhere in between there. Okay. And then that probably would be your best bet, but just look at Tanner's so that you can see that. That stages can show you where in puberty that child is and what to expect next. Part of puberty and part of adolescence is, girls want to have sex. They don't want mommy and daddy to know. And you, as a nurse, seem like the person to ask. And the question has always been, can a nurse tell an adolescent without parental consent about birth control? Yes, we can. We can counsel them on the benefits and risk of oral contraceptives or whatever in written and oral form. That's it. You cannot put your opinion there. Piaget. Remember, Piaget is all about figuring things out. Knowing that if I cry, somebody's coming to come get me, right? Knowing that if there was a toy there and I don't see it, I know I can still find it because it's still there. Object permanence. I can think. Erikson. This is psychosocial. This is all about dealing with society around them. Again, needs are met with the infants. They know how to get somebody to help them, to change them, to feed them. Remember with Erikson, it's understanding and school ages, infants and school age and adolescents are the ones that Erikson loves to pick on for some reason. Infants, it's all about trust and mistrust. That's guaranteed. You're see that either HESI or your NCLEX for sure. School age children. Remember with school age children that they need to be challenged to do things, but when you challenge them, it needs to be something that they can accomplish. You don't want to give them something they can't accomplish. For instance, you get a kid who's in a hospital a long time for whatever reason, and you give them something to do besides homework, etc. Let's say it's a puzzle. You're not going to give them the 5,000 piece puzzle, and they're not going to accomplish that. But maybe 150, 200 piece puzzle, not so small, not the same color pieces, but something that they can do. But again, according to the age, it's ages 6 through 12, school age. Again, give them something that they can accomplish, but is a challenge. So they feel good when they're done, right? Industry, what they do well. So let them get it accomplished versus inferiority, what they can't do well. You don't want to have them fail so they feel inferior. With adolescents, remember, it's all about me, who me, what do I look like? What do I want to be when I grow up? I'm so confused. And then it gets into a lot of our relationships with the adolescents is they want to tell you something about themselves, or you need to find out why do they have urinary tract infections all the time, or why do they have rectal bleeding, or why. And all of those things could be those sexual things. So again, you can have parents leave the room and speak to a child one-on-one, a doctor, a nurse, and the parent's gone. You don't have to tell the parents what they said unless that information is going to hurt themselves or others. All right, let's go through some of the conditions now. Hematology. So we learned about bleeding coagulopathies and bleeding. And we know hemophilia means there's some factor that you don't have. So when you get cut, you bleed, and you're going to bleed and bleed until you get the factor. So you've learned your toddler, your aged 1.5-year-old toddler has hemophilia. What do you need to do to protect that child? Safety at home, right? Pad the sharp furniture. You're going to stop them from running? Oh, no, it ain't going to happen to a toddler. So protect the environment on those children. That's the biggest thing, protect. With those children, for instance, with the hemophiliac, older kids out riding the bike, fall down, bang, on the knee, and it's big, it's starting to swell, it's ecchymotic. Well, we're going to do that good old rice. Rest, ice, contain, and elevate. And we're going to be giving that factor at home. And I've gone over giving factor at home. It could be IV, it could be intranasal type of things that we can give. Desmopressin, which is used for diabetes insipidus, is used for mild hemophilia. So it's something they would use. So again, hemophilia, stop and just do the rice and then give the whatever bleeding factor you need to at home. Nosebleeds. You probably had this one on your NCLEX questions. Forefinger, thumb, press the nose at the bridge and lean forward. Why do you lean forward? Because it's bleeding. And if you lean back, you're just going to drip blood into your stomach and you're going to end up vomiting. So lean forward, okay? Hold it for 10 minutes. And after 10 minutes, if it's still bleeding, need to get to medical care. Now, platelets counts are low. Now, I've mentioned these, for instance, with leukemia. I've mentioned this, with different types of things, ITP. Now, what if you just have a patient who's in the hospital and you notice platelet counts are 20,000 or less? What is going to be your concern? Well, low platelets causes a bleeding, right? Prolonged bleeding. You need platelets. It's part of those things you need to stop blood from bleeding. So if you have a patient that all of a sudden you notice platelet counts are low, what you're going to do is put this patient on bleeding precautions, which means what? No IM injections, right? Protect them, keep them safe, and then follow up those platelets, monitor those lab values. Now, sickle cell disease, we've learned it's all about how cells get stuck in bifurcations. Those sickle-shaped cells get stuck. And then when they get stuck and blood can't get down, it swells and it causes, so much pain. It's hot, and redness, swelling, and that pain. So how do we treat? How do we treat it? And it's basically, let's prevent sickle cell attacks. Number one priority is keep them hydrated. And that's what causes sometimes bedtime wetting because they're so hydrated, right? Also, you don't think about it, but I'm from Florida, so I don't. So if it's cold outside, make sure they dress warm. So it keeps the vessels open and dilated so blood can go through, because even that can make a sickle cell be clogged. So any immunosuppressed child, I put ALL here, but sickle cell could be, hemophilia could be, cystic fibrosis, rheumatoid arthritis, any of those immunosuppressed people, children, the priority is always to prevent infections. private room hand washing. Sounds good, right? And then iron deficient anemia. So if we're not going to eat those green leafy vegetables and liver, of course, and use the diet, we can give a supplement. Now, children usually get the liquid. Remember, iron needs to be digested in the stomach to be useful for the body. It uses gastric acid to break it down. So never milk, never after meals, always before meals. You want that good acid in there to eat up the iron to get it ready for you. And if you drink orange juice with it, it's extra acid, it breaks it down better, and it's more useful. Through a straw so you don't get your teeth all brown.
Quick question, Professor. So
Sure.
for a person who has acid reflux, how does that work out with them in the orange juice and the iron?
Well, depending on the age of the child, maybe we'll give IM dextram instead. If it's
Okay.
that bad, yes, there's always alternative. That's a great question. That would be that person would have to eat real well because of the reflux, and then eat those, more iron fortified foods. And if they can't tolerate the iron, it would have to be the injections in order to get their iron levels up to get that energy, or else they'll be fatigued all the time. Yes, thank you so much. So orthopedics, think about bones, think about juvenile idiopathic arthritis, right? One of the big things about JIA is all about keeping mobile. So you all don't know, or maybe you do. I have rheumatoid arthritis. And I know in the morning or in the middle of the night, I go to get up and there's no way I can run. I have to slowly get up, sit there, stretch out, wiggle my hips, and slowly start to walk. It's that keep them moving. Children, one of the best things, and for me, it's the only thing I'll exercise with, is the swimming pool. You're weightless, you don't know you're moving, you're enjoying the water, you're floating, and it keeps all of those joints mobile, which is what you want. Now, school age children, adherence, compliance, how do you know that they're going to be doing what they should do? Again, you have to educate them so they know what they're going to do. You never, assume that they're going to read instructions or listen to mom. I mean, remember, I have done research on school age children. That's at age 6. They are amazing to teach. And I know even younger kids could. Um, Rewards are always good when they're doing what they need to do. And then again, school age children, after we speak with them, give them written instructions. I would give the parents instructions and the child. So now the child is now responsible also. And that's what has to be done. So you have a kid, and I'm telling you, probably the most common way to break bones is falling off monkey bars. I hear it all the time. Fell off the monkey bars, and it's right on the elbow. So what do you do first? You get a kid, fell down. What do you do? Well, isn't it rice? Rest, ice, contain, elevate. Well, when they fall off, what they do is immobilize it, hopefully elevate, put ice on it. But as nurses, when we first see them, we need to make sure that blood is flowing to the fingertips, to the toes, wherever that break is, right? Capillary refill, very important that we check. Blood is flowing. Now, when we have scoliosis greater than 45%, they are going to need to have surgery to correct that S, because that S is pushing up against the lung space. They don't breathe well. You think it's like this, it's pushed up on the upper portion of the chest. So one lung is really small. So this is something that really needs, correction, whether physical therapy or surgery. Well, apparently, this child was greater than 45%, needed a Harrington rod. Now, what they do is the spinal column, they connect to each tip and they put rods down each side and they straighten it out as much as they can. It'll never be perfect, but It takes time for it to adhere to the bones. So post-operatively, big thing is to log roll them. Put a pillow between the legs, log roll them, just like older people, fractured hips. Same things. Keep that back straight. You need another person with you. With osteomyelitis, one of the things, just because they get osteomyelitis due to a puncture wound or whatever, also know, are they somebody who gets frequent infections? You might treat it longer or with stronger antibiotics if this was somebody who was always sick versus somebody who's never sick. And antibiotics will actually work better on that one. So cardiac, this is the one that you're all afraid of. Cardiac, the respiratory area. Now, cardiac, what do you need to know? Well, I've already warned you, you need to know all the names of the meds, right? Indomethacin, prostaglandins, Synagist, those big three things. And your big drug is always digoxin for hearts. Those are the ones. So Kawasaki disease. Kawasaki is a systemic vascularitis. Our big concern is a coronary aneurysm. That coronary aneurysm will be checked by an echocardiogram. It is a virus. We're going to be given IVIG and we're going to give aspirin. There was a question about why do we give aspirin to Kawasaki disease? Well, you have an inflammation of vessels and little microemboli being formed. Aspirin thins the blood and prevents clots. So aspirin, as simple as that, why we do it. Now, prostaglandins keeps open the PDA. It's a slow, continuous infusion. One of the side effects that we need to watch for is bradycardia. And then I'm going to tell you another one that's on no exam, just that you know, and it's hyperthermia. They get little elevated temperatures. It's not on an exam, but I'm telling you, you want to work in the newborn ICU, it's one of the side effects. But bradycardia, all we would do is turn the rate down. That's all we would do. Indomethacin is done for what? It's done for the PDA that we can give medication or do a medical closure. So we give 3 doses of it. And how do we know it's working? This is one of the things I love to give because I used to listen to the heart and then listen to the murmur. That's this big washer machine sort of murmur before you start the indomethacin, and slowly you hear that murmur decreasing. Big concept, congenital heart disease. They're not doing well. Their condition is deteriorating. They've gained weight. What do you think is going on here? Well, a sudden weight gain, congenital heart defect, think congestive heart failure. So you're going to assess the respiratory status. What are you going to hear? I'm going to hear fluid in there, aren't I? I'm going to hear gurgles and bronchi and rails and all sorts of stuff. And as my heart fails, my blood pressure is going to go down also. Heart rate's going to go up, trying. How are you going to treat it? Let's get rid of the fluid, diuretic. Let's let the heart beat better. Let's give some digoxin. And we're going to watch the weight be lost by doing intake, output, and daily weights. Cardiac catheterization, post-catheterization, as I've said, the biggest concern is the punctures where they've gone into the femoral artery and the femoral vein. It's in the right groin. And these are big catheters. And our concern is bleeding. What do you do if it bleeds? You take your 2 fingers on an infant, put it right above them, push it, and just put pressure and then call for help. That's it. Put on a new dressing. Remember with digoxin and infants and children, we do the same things for digoxin that we do with adults. We're going to check the heart rate. If it's less than 100 or whatever the doctor says, we'll hold it. Potassium level, it has to be within normal limits or they can go toxic, which we know Digibine or Digimune Fab better be around the bedside just in case. So sometimes when we're giving digoxin, we might just see a heart rate decreased and go, oh, that has to be digoxin that caused that. Or we might see a vomiting, and that could be digoxin. So let's go check that dig level. Let's go check that potassium level again. Okay? So dig, there's a couple ways that we look at it. Look at heart rate, look at vomiting, know when to give it. When you have that weak heart, that's when you're going to give digoxin.
Did you say what the antidote was for digoxin?
It's Digibine or digoxin immunofab. And rheumatic fever is caused by a bacterial infection, strep. Remember, everything, the chorea, that weird movement, the rash, the lumps, the sore throat, the everything all goes away except the mitral valve damage, if it's damaged. That will have to be treated. But everything else will disappear with long-term antibiotics. So, urinary system. Now, sometimes you might see a child potty trained, and then all of a sudden they start bedwetting. One of the things to check for is a urinary tract infection. We know the other thing is that, urgency, that, where they're wiggling, that they're running back and forth. That could be urinary tract infection. One of the ways to help prevent them is increasing fluids. That's the biggest way. And of course, girls wiping front to back, and boys making sure that we clean underneath the foreskin. And then, of course, making sure they go when they have to go and not holding it. And no bubble baths or bubble baths. Cryptorchidism. This is when the testicles are up inside the abdomen and not in the testicular sac. This is one thing that the pediatrician checks on the first visit. Remember, if it's cold, testicles suck inside. So if the room is warm, you're going to have a better chance of feeling them. Also, just because you don't feel them this visit, they might have been there before. And that's very important information for the physician. Have they been down before? Okay. Remember long-term antibiotics. There are some that we don't are as concerned with the metabolism excretion, which means the liver and the kidneys and kidney damage. Now, when we're talking about vancomycin, these are your aminoglycosides. This is one that you may or may not remember from pharmacology. This is one where we do peak and troughs because they are so dangerous. One of the things it can do is it can affect hearing. So we'll be monitoring the hearing on these children as we give this medicine, and we'll tell the parents also. Another thing it can do, it can cause kidney damage. So we'll be monitoring intake and output on these children, and we'll be teaching the parents to monitor urinary output, okay? Very important concept there. Now, nephrotic syndrome, that's not kidney failure at all. Remember, the kidneys are working, but the kidneys are saying protein, yuck, I don't like you, and spits out all the protein, including protein from inside the blood vessels. So when inside intravascularly protein is gone, the body doesn't like that fluid balance. So it pushes fluid interstitially. So now this child is swollen everywhere. This is generalized edema, right? Now, how do we get that fluid out? Well, you got to get the protein back in the child. And we can do that by giving intravenous albumin. Albumin is the same name as protein. Protein is albumin, albumin is protein, okay? Use those, it's, in the same sentence, they're fine. Now, put protein back inside the blood vessel. It says, oh, we need more fluid to balance it. It pulls fluid from interstitial, from the tissues, back inside the blood vessels. And then what they usually do is give furosemide or a diuretic behind it. And we're going to see them to start urinate, urinate, urinate. How do we know it works? Besides, of course, urinating, is we're going to see the edema decreasing. Makes sense, doesn't it? Simple things. Don't think of these big things. It's always simple. More urinary is hypospadias, epispadias. One of the things about this is the baby's born, and either the whole, it's not at the end of the penis, the urethra, it's either on the bottom, hypospadias, or on the top of the penis, epispadias. Treatment is the same. One of the big concerns is they have to keep the foreskin, which means no circumcision. This might be an issue in some religions, like the Jewish religion. They like to do their bris. Well, this one cannot because they need the foreskin. And you can see the picture down below. They fillet the penis out. Okay, they create a hole, a cavern to go from the penis down into the bladder. They put a catheter in there to maintain the lumen. They close it and they use the foreskin as part of the closure. So they don't have a foreskin, they cannot do the surgery. This child is going to be urinating and it's going to squirt up or down because they don't have what they need to do it. It should be done before they're potty trained. Anything we do with the penis or with the anus, any of those things must be done before potty training. Nothing should interfere with that because then they get into body dysmorphic, if we wait till later. So we have to do it before, if at all possible. Remember Wilms tumor is that kidney tumor. It can cause hypertension, remember? We can give an allopril for it. That was some of the questions. Now, one of the things is do not touch that abdomen. Now, the other thing is, you have this tumor in the belly, and we're going to be treating it with radiation and chemo. We don't do any biopsies on this at all. It's just like doing do not touch. If you do a biopsy, what have you done? You've opened it to the peritoneum and now you've just spread it without manipulating it or moving it. So no biopsy. Chronic kidney disease. One of the things is vitamin D and erythropoietin and all the secretions of these things, and something called osteodystrophy, which is a disfigurement of bones, whether short, crooked, long. I mean, something's not right there. So chronic kidney disease can cause osteodystrophy. And we are going to be needing to give this child calcium, vitamin D, and this is erythropoietin. This would give that sub-Q one because chronic kidney disease does not make enough erythropoietin. But we can stimulate that by giving the synthetic injections. Familiar nephritis, just like rheumatic fever, it's caused by strep. How do we treat it? Long-term antibiotics. Usually we start to see a child not urinating, and that usually brings them into the doctor. One of the concerns, working in the ER for many years, any boy coming in complaining of pain in their testicles is considered one of the highest urgency charts. They're brought immediately back, do a urinalysis, get them over to ultrasound, and if they need to, right up to the OR, because we're trying to save their sperm for future to be able to have children. So respiratory. Respiratory in adults and children, the one big difference is your infants, right? Infants do nasal flaring and grunting. That's, and of course, the retraction and the bobbing of the head and all that good stuff. But infants, flaring and grunting are your biggest, oh my goodness, we're in trouble. Now, a child comes in drooling, garbled voice, definitely looks epiglottitis, right? No air can get in. This child is now almost hypoxic. Put the kid in the room, what's something that must be there now? So you get your, who's ever working with you, go get me a intubation tray and a tracheostomy tray, put it at the bedside, because you may need to have to do it then and there, because that epiglottis has covered the trachea, air can't get in, okay? Now, one of the things with epiglottitis, it's croup that we didn't treat in time. Because remember, croup is upper airway too, swelling upper airway, inspiratory sort of problems. Now, many children come into the hospital, they're barking. We give them a little racemic epi, a little bit of steroid. They sound good, we send them home. But there are times once they get home and the epi wears off of the back of their throat, all of a sudden they can't swallow secretions. They're turning into epiglottitis. That is an emergency. Does that make sense? Because we know croup untreated will equal epiglottitis. So if we're treating croup and we've treated them with racemic epi aerosol, which is quite a big treatment, send them home, we need to make sure that parent knows if now they're not swallowing, it's getting worse. We need to do more than what we've already done. And they need to be here now in a room with an intubation tray and a tracheostomy tray, because now we're really concerned. Remember RSV? It's the first year of life only. It is your very immunosuppressed, premature respiratory problem infants. And it is a vaccine that we give monthly to prevent RSV, respiratory syncytial virus. It's once a month from winter to early spring. This is a contagious virus. So you get an infant in, has a fever, coughing, respiratory distress, put them in a room alone. And make sure you know, have they had their immunizations? This could be pertussis, it could be other stuff too, okay? So always put them in their own room just to be safe. Cystic fibrosis, the first time where we're suspected of cystic fibrosis might be at birth, right? No stool at birth. And then the parent licks the skin and goes, oh my goodness, my baby tastes salty. Well, you hear that stuff. What you're going to do is tell the doctor and get that sweat chloride test done. Remember, they just sodium chloride just come out of these children. So cystic fibrosis. Why are we giving chest physiotherapy? Well, cystic fibrosis is like, it's nutrition and it's also respiratory that we're worried about. So chest CPT, we need to give our bronchodilator, and then we need to do chest CPT because now our lungs are open before meals so that our lungs are up and moving good. During meals, as we start to eat right before, we need to take enzymes. Remember, we can open capsules and sprinkle them. If they're little extend things, we can't chew them or crush them. They need to be swallowed whole. If it's the powdered one, we need to rinse our mouth. And remember, these are things that we forget to increase as children gain weight and get bigger. So as they get older, increase doses. Remember, our albuterol is our rescue. Albuterol, Proventil, is given when a child can't breathe. Okay, let's go into some GI stuff. All right, diarrhea. Remember diarrhea? Our big concern is now, especially younger kids, is that skin breakdown in the buttocks. This thing we forget. You know, the kid comes in diarrhea. We think about dehydration, think about giving them, hydrating them, um, evaluating. Can they take oral or are they too far gone and need IV? Always remember to check the diaper area. That's what this is telling you. You get a child in with abdominal pain. Now, abdominal pain could be a bellyache. It could be things like appendicitis. It could be many intussusception, right? So when you have a child coming in with abdominal pain, the important information to ask, tell me where the pain is. Right lower quadrant, belly button, epigastric, they all have different treatment, okay? Now, times, and I think the biggest surgery you can imagine is you have a child who has a Wilms tumor. So this is a tumor on the kidneys. So you open the belly, you have to move all the intestines and organs out of the way and go to the back and deal with the tumor on the kidney, which is in the back, on the bottom of the barrel. Okay. So you've manipulated all that stuff. Status post-abdominal surgery like that can develop paralytic ileus, right? This is one of the ones that you'd be concerned. So, paralytic ileus, what are you going to see? Now, it makes sense. I've had abdominal surgery, manipulation, even post appendicitis, right? There could be all that manipulation, or even one that's ruptured. Think about that child keeping the bowels moving. That's why they get them up out of bed, walking, coughing, deep breathing. We want bowels to start moving. But if they don't, it is horrific colicky abdominal pain. And not only that, they're getting nauseous, they're going to vomit, and their belly's going to get huge. All right. And that's because of all of that manipulation we had to do for surgery. So expect it. And if you expect it, you can prevent it. Pyloric stenosis, this is that projectile vomiting. So you get an infant in with projectile vomiting. What are some things you're going to look at? Well, as I said, I take my hand first thing, I put it underneath the xiphoid process, and I'm going to feel that little olive. I call it a little marble. It's this hard, and it's pretty big for a little, infant. It really is. So with pyloric stenosis, they are eating, they're happy, and then they vomit like crazy. So they could be a little dehydrated. That's why we give an IV before they go to the OR, right? Just IV fluids, get them hydrated. They could be irritable because they're hungry. Give them a pacifier, right? Those signs of hunger, we know what they are. That's, that crying, being irritable. So make them MPO, give them that IV, and then they'll go to the OR. Post-operatively, we'll start feeding them slowly when they get that irritability again. So intussusception. You get an infant in, a toddler, about 2-year-old. That 1 to 3-year-old is that great area for intussusceptions. Intussusception is when the intestines suck into each other and then they swell and they can't move out. So hydration is huge. You can see that. But when these kids come in this severe abdominal pain, we immediately say nothing more to eat or drink because we know we might have to do a procedure, whether it's a barium or air enema in radiology or to go to the OR. So if this child was positive intussusception on a ultrasound and they're lethargic, we know it's beyond just doing a procedure. This child needs to go to the OR. The best we get that fluid in and clump up and hydrate that intestines, probably the least amount's going to have to be taken out. So they have to take a chunk out and reconnect it. So hydration and NPO. And they might do an IV antibiotics, but it's not important on this one. Okay. Full stop. Yes. Okay, gastroesophageal reflux disease. Well, we have older kids that have it, right? These are the ones that are coughing, many aspirations, that have, pain in their esophagus, in their chest type when they eat. So, a diet of bland foods. Now, you're not always given choices that have completely. They say not too much sugar, a plain sugar cookie, it's better than spaghetti and chocolate and soda. So picking the least of all evils would be a diet that you would choose when you're looking for uh, reflux food on the older children. Okay. Now, at birth, sometimes the liver's not connected to the common bile duct. There is something we call biliary atresia. So the liver doesn't connect. So no bile is getting to the intestines for digestion. Bile digests fat. It also colors the urine, that yellowish brown stuff. So when we have an infant that we didn't suspect, didn't know, all of a sudden they're having stools that are looking pale, clue. Their urine is becoming that bile colored, tea colored. And of course, the sclera, that's, the no brainer. We know that's the jaundice. Those are the symptoms of biliary atresia. Pale stools, urine tea colored, scleras yellowed, and then overall jaundice. If it gets to that point, they need surgery. They need to put a duct in and they need to get the liver connected somehow. I've seen it before. Okay, neuro. So you get a child into your school nurse and you get a child in and they're telling you it's an adolescent. Their ears are ringing, ringing. What do you do first? Well, you got to look first to see what's in there. I have found alive cockroaches in ears before. I saw a live bumblebee in an ear before. Children and adults. And they actually put mineral oil in it and try to smother them and float them out, is what they do. But, this could be a hearing issue. It could be something in there. Again, if something's wrong, you look first. Look, that's what you do. And then you investigate further. Remember with meningitis, all the symptoms, the neck rigidity, the fever, the photophobia, blah, 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 blah. Always know that they need to determine viral or bacteria. You're going to be doing a lumbar puncture. Left lateral decube on the side and make sure that they stay flat so we don't get any headaches afterwards. And that's all your lumbar puncture. In seizures, all about safety, isn't it? Turn them on their side, suction for vomiting, take all the toys out of the bed down, pillows out, pat it, have an IV ready, maybe for, they'll get some more medicines. Also remember with seizures and teaching, these children can't be like left in the middle of a pool alone if nobody else can swim with them. They might drown, or in the middle of a lake. They shouldn't be doing things by themselves where nobody can see them. They could have a seizure and nobody would know. So that's one of the safety precautions about seizures. Febrile seizures, you'll always hear it. Parents, does this mean my baby has epilepsy? No, it doesn't mean that. One febrile seizure doesn't mean it. Epilepsy is more than one a day, and nothing instigated it. In febrile seizures, the fever went from 0 to 102 in half an hour, and that's what created the brain to spark. Usually they grow out of it by 6 years old. Myelomeningocele is that beautiful picture down there. It's all about the meninges, spinal cord, and nerves have been stretched and pulled up and out on the lower back. What is our biggest concern? Well, infection, skin integrity, cover it with normal saline liquid, and then sterile dressing, right? Also, there's going to be dead nerve sensation in the lower area. Watch out for urinary retention. Many of these children end up catheterizations for life. So some of these are, and we always, just because we've learned a long time ago, we put them latex allergy from the start because they will have multiple surgery, okay? Remember, latex allergies, they can be bad, they can be anaphylactic, could be breathing, respiratory allergies. I mean, I just swell up like a balloon on latex. So yes, latex can be, I can smell when they take their gloves off of latex and pop them off into their garbage cans, the dust would get in the air and I could taste it in my throat. And I would, yeah. So the doctors learn, let me get out of here if you want to smack your gloves around because I can't tolerate it. So more neuro, Duchenne muscular dystrophy. Remember, it's mom, X-linked recessive trait, and we need genetics on it. Know that the way that we can diagnose it is through this EMG, electromyography, all right? And what it does, it puts a little shock, a little electricity buzz, and you watch the muscle, how quickly it reacts and how strongly it reacts. And this telling you is they're decreasing muscle strength. Remember, it's like running a marathon. When the kids come back, their muscles are going to hurt. It's like you going to the gym after not going for 2 years and working out like a crazy person. And how do you feel? Well, that's what this little child feels like. You have worked all their muscles. Now you get the understanding. They need some acetaminophen or some ibuprofen, but it is temporary. Remember with eye injuries, you get something pointed in an eye, it's sticked in, you've got to put that good old buck shield on. If there's an eye injury, put both eyes down because you don't want those moving underneath. You want to prevent movement and then trying to get those things, whatever in the eye could be pushed in more. Remember nystagmus? Do an eye exam, do the 6 cardinal positions of gaze. It's one of your health assessment things, right? Remember hydrocephalus? I said this earlier. The earliest signs and symptoms is that increasing head circumference. And the next thing you look at, of course, is that fontanelle. Now, a ventricular peritoneal shunt. This is for the child who can't manipulate the cerebral spinal fluid in their brain and their spinal column, and they have to have a shunt in so that their heads don't get big because they can't tolerate it. It goes into their fourth ventricle, out behind the ear, down their front, into the peritoneal cavity. Now, one of the things is as they get older, you'll see children come in complaining of headache and vomiting, and they have a VP shunt. This again is one of our high priority charts. They're coming in quick, okay? And this child will be sent for x-rays, probably to the OR, in order to get that shunt revised. Usually they disconnect. So the fluid is building up in their head. So you come back to work the next day. How do you know the VP shunt revision worked? They came in with a headache and vomiting. The next day, no more headache. They're not vomiting and they're eating. As simple as that. Okay. All right. Endocrine. Remember, height, weight, always your telltale signs for many endocrine issues, right? It's also nutrition, height, weight, always something to look at. So, how do you detect hyperpituitarism? Too little growth, too much growth? Simple, height and weight. Remember, the parathyroid's all about calcium. So it's all about muscles. Remember, calcium, magnesium are all about muscle strength. Whenever you hear questions on that, think about too much calcium, you can't move your muscles. Too little, you're just floppy. All right. So not enough, you can't move. You're weak. Diabetic ketoacidosis, plan of care. Remember, it's an IV bolus of saline. It's going to be regular insulin, a slow continuous drip, and we're going to adjust it according to blood sugars. And children with diabetes, they want to play sports, and there's no reason why not. But remember, these are children that should, the type 1, check their blood sugars before they go into sports. And if it's on the lower side, they need to eat something before they play. If it's 170, you can play. Just keep hydrated. But again, it's being aware of their blood sugars, how it affects them, and having the snacks and to hydrate. With diabetes, children are taught rotate, rotate, rotate the injections. Arms, abdomens, legs, rotate them. Very important. They're going to be giving injections for life. Knowing the signs and symptoms of hypoglycemia, sweating, shaking, headache, nausea. And then there was a question regarding TSH and T4. And it's why it's about breastfeeding and all of these hormones. Just know the TSH is high, T4 is low. And if it's T4 is high, TSH is low. They're converse to each other. They're opposites. All right. Now, you have an adolescent, BMI is high, 95%. What do you think? Well, 95% means they're obese. Number two, what else could be happening and going on? Um, you know, with the BMI high, if they're urinating a lot, thirsty a lot, could be diabetes, could be urinary tract infection. Again, you have to think what can cause a BMI to be high? Probably this has to do with urinating too. So it could be as simple as a UTI, but it could be also diabetes. So again, you have to rule out all the symptoms. So some of the common kids' diseases, we didn't get a chance to go a lot of these. So I put them here. Impetigo is an extremely contagious staph infection. Christian had it when he was about 4 on the back of his leg. Mom thought it was a mosquito bite that he itched too much, but it kept spreading and spreading. And I'm like, nah, impetigo. So I started treating him with the Bactroban, and I had to get the oral antibiotics. In fact, that was the first time he ever had antibiotics because it wouldn't go away. Do not pop those fluids. It's a really resistant and it spreads. So oral and topical, Mupricin and Keflex. Those are the 2 things that they give for it. Conjunctivitis, this is a big thing. Remember, with conjunctivitis, you clean them with just warm water from the inside out. And if you have to put ointment into any person, let them know and instantly they're going to see blurry vision. If you put liquid, drops in, they look good. But what if there's blurry vision? A kid might be upset. Warn the child. The vision will be blurry. So you had a kid who went outside, was in by the lake, by the pond with his friends, comes home, you found a tick, you took it out, and now it's 2 weeks later and you find a fever. What do you do? Well, number one, you would check the rest of the body, make sure that there's no tick that you didn't miss, always. And then, of course, get them to the doctor and let them know that you now have Lyme disease, and they treat it with antibiotics. Tetanus, stepping on that rusty nail, right? Number one, always check their immunization status. We do now our TB, and we do tetanus with it. The tetanus and the TB, tetanus toxoid. We also do these now with every 10 years, right? And we also they're telling even pregnant women to get it before to get it done. So tetanus is an important thing, the status. And then after they get that, don't forget that there's still a hole in their foot. Clean it with soap and water, because tetanus can go to really bad neurological, respiratory, bad things. Remember chicken pox? Remember, if you have a kid that has macules, papules, fever, that kid is a possible chicken pox until it's ruled that it's not. Know that 2 days prior to the onset of the rash, until all the lesions are crusted. They are contagious. So they're contagious before we know. And then they can't go to school until all of the lesions are dried over. If they're oozy, they are spilling off, chickenpox to everybody else. You have a child with head lice, make sure you check in the hair follicles. Remember, it's a comb and we comb it out. Otitis media. This is something I think every kid gets more than once. How do we decrease the amount of otitis media? Well, a lot of times we can. It's that swapping spit in daycare and the germs, etc. Go oral pharyngeal up into the ears. But breastfeeding on your infants, your younger children, is a great way to avoid otitis media. And of course, anybody should not be smoking around children. Avoid smoke exposure. Now, ADHD, you have children that they are very hyper and they can't sit down. So there's things that need to be done. You need to have them on a schedule. They can be placed on stimulant meds to help keep them calm, organizational charts, always do that consistent scheduling. And the one thing is, this is the place where you sit, you do homework. So nothing else can be done. It's not playing games, it's not coloring, it's not drawing, it's only for homework. And this child needs that. The epistaxis nosebleed, again, same thing, pinch the nose, 10 minutes. All right, and here's some little things to pass on. A low neutrophil count. I don't care if it's that chemo child or if it's a child that's came in with overwhelming sepsis. Whole kid comes in low white blood cell count, low neutrophil count. Remember, this is going to be a child that has no immune system, especially if they have a fever. This would be the child that, if there was a group of patients you need to see, this is your priority because you need to get antibiotics started immediately because they have absolutely no immune system. That means a low neutrophil count, 500 and less. And it doesn't matter if they have other conditions. We sort of relate it to leukemia or one of those conditions, but I'm telling you, it could be any. Infection control is all about washing hands. It's all about parents knowing if they're on isolation, especially respiratory, not to come out without masks on because they could spread it, keeping their children in their rooms till whenever they can take them out, etc. Immunosuppressed children are the ones that really, they come into a hospital, they're coming in, these children don't have any backup to them. They need their treatment as soon as possible. They come into a hospital and they need a bunch of tests done. They need to get up to their room first, away from people. And then we can carefully get them to x-ray or to lab or whatever needs to be done. But immunosuppressed children, get them into their rooms right away. And because we have to monitor their immune status, get a temperature. It's going to tell you, is that child already at more risk? With getting immunizations, a lot of the problems is we're giving like 4 at 2 months, 4 months, 6 months, right? And these children, their legs get red and swollen and they hurt. So what can we do? Well, we tell our parents up to 6 months old, they can have Tylenol, acetaminophen. After 6 months, they can have ibuprofen if that's what they want, or they can, alternate it if they need to. But one of the good things is just to pedal their legs, which means get their knees up and down, get that muscle moving after those injections. And that actually helps in absorbing this immunization, the liquid, and it decreases the amount of discomfort with it. And of course, cold packs are great. Remember, off and on, just don't leave a cold pack on. You can cause frostbite to a leg, so off and on. There was a question about when do we give MMR? We give it at 12 months and somewhere between 4 to 6 years old. Again, rheumatic fevers here, caused by strep throat, remember everything will go away except the valve problem. Now, I had one HESI that had 4 acid-base questions. So I'm going to tell you 3 of them, and you're going to, the way I think you can understand them. So let's start out with metabolic acidosis. What would cause it? Well, you have to get rid of alkaline. How do you get rid of alkaline? Well, diarrhea is the biggest one. So when you have diarrhea, all of your digestive enzymes are alkaline. So diarrhea, all the alkaline is being lost. What are you left with? Metabolic acidosis. Now, you're vomiting. You're vomiting. You are vomiting acid. What is left? Metabolic alkalosis. And then the other question is you're anxious, fearful, you're hyperventilating. That's respiratory alkalosis. Okay. So, in conclusion, guys, remember to read the question. When you think you have the question, go back and read the question and make sure you're answering what it's asking for. It could be the opposite, right? This is the most common mistakes. You guys are going to do great. I wish you all the best. If you need more help, let me know. If you want this audio recording the quickest, go to my YouTube site, Professor Bogart, Pediatric Nursing, and it will be there first. You should all have the PowerPoints because I believe I sent it to all of you. If you don't, let me know. Thank you for coming, everybody.
I don't have
Hey,
it.
that, oh, I'm sorry. The cahoots was